Now that you know about the background, the theory, and the pathology of aortic problems, it's time that we take a look at echo examples. But first, I want to cover a topic which is also very important, and that is that of aortic plaque. Now, aortic plaques usually can't be seen as well with the help of transthoracic echocardiography, but it needs to be discussed to complete the entire spectrum of the diseases of the aorta. The presence of aortic plaque denotes an increased risk for coronary artery disease and myocardial infarction. It increases the risk for embolism and stroke, and it is a risk for aortic syndromes. Furthermore, we also know that it is not only the presence, but also the severity, especially the thickness of the plaque, which play a role. If we look at the risk of stroke, if the plaque size is more than 4 millimeters or less than 4 millimeters, then we can see that the odds ratio is very high if we have a plaque size which is more than 4 millimeters. The risk increases 9 times. Of course, the plaques have to be in the ascending aorta to get a stroke. Where do we usually find atherosclerotic plaques in the aorta? Well, they can be found anywhere. But the sites where they are most common is in the region of the aortic arch and also in the cranial portions of the descending aorta, and very often in the region of the aortic valve. When we perform a carotid scan, we do it to visualize plaque and atherosclerosis. But why should we not also be able to visualize plaque and atherosclerosis in the ascending aorta? Of course, we cannot use the same transducers, and the image resolution is not as good as we have it for the carotid scan. But as you will see in the following demonstration, it can be done. What's very important and what we always forget is that patients can also be assessed with respect to atheromas and plaques in the ascending aorta. And this is a patient who has a known coronary artery disease, an inferior infarct. And if we take a look at the ascending aorta, we can see that there are calcifications here in the sinotubular junction, both here and here, which are indicative of atherosclerosis. And the TE in this patient also showed that he has plaques not only in the ascending aorta, but also in the aortic arch and also in the descending aorta. And here's another example of a patient who has several risk factors for atherosclerosis. Hypertension, we can see left ventricular hypertrophy, and we also see mitral annular calcification. But focus on the region of the ascending aorta where we really see a nice plaque right here close to the aortic valve. Again here, if we zoom in on the ascending aorta, this is the plaque, partially calcified. If the plaques are circumferent and heavily calcified, we use the term porcelain aorta. And a porcelain aorta poses an increased risk in the setting of heart surgery for cross-clamping, graft placement, and also for cannulation. Then we have an increased risk of thromboembolism and also of injury to the aorta. But let's turn away from transthoracic echocardiography and turn to TE studies to see how plaques can look in the descending aorta. Here we have a normal aorta. We see no plaques, while this patient here shows at least moderate plaques already, which are partially calcified. We can see the artifacts right here. This is a patient who has a plaque which is mixed. We have fibrotic portions and also calcified portion. While this patient has a very large plaque which protrudes right into the lumen and is heavily calcified so that we have shadowing of this portion of the image. The surface of the plaque is rather irregular and we even have ulcerations. Furthermore, we see small mobile portions on the plaque. Possibly this is a ruptured plaque and already a penetrating ulcer. This would be called a complex plaque, which further increases the risk for stroke and thromboembolism. Sometimes it's really surprising what you can see with the help of TE. And if you have patients who have such massive plaque, you can assume that this is only a general marker of atherosclerosis and that the other vessels are equally affected. Very often we have an association with coronary artery disease. But now let's turn to the next topic, to the topic of aneurysms and what we can see with echo. Not all ascending aortic aneurysms look the same. Sometimes we have a pure ascendance type aneurysm where the sinus looks normal and we have the aneurysm further cranial. Sometimes both the sinuses and the ascending aorta are involved. I call it the so-called sausage-type aneurysm, and sometimes we only have the sinus which is involved. This is the typical form we see in Marfan disease. Here are a few tips. Usually you will see an aneurysm in a peristernal long axis or short axis view. But if the aneurysm is very large, you can also see it from a right peristernal view, because then the aorta projects itself also to the right of the sternum. Don't forget to also measure the ascending aorta. And if you have an aneurysm of the ascending aorta, also consider that it can also extend into the aortic arch. Therefore, you should also use a suprasternal approach. Here is a special form of aneurysm which only involves the right coronary sinus. This you can also see with the help of transthoracic echocardiography. The patient on the left has an ascending aortic aneurysm which involves the ascending aorta and to a certain degree also the aortic root. Remember, however, that we do not see how the aorta continues here, so we cannot say if what we measure here is really the maximal width. Such aneurysms can also be seen in a 5-chamber view. Note that in this case it's often very difficult to see the right atrium, and you can also see how the aortic aneurysm extends towards the right. This image shows you a patient who has a prosthetic valve and also an aneurysm of the ascending aorta. Why does that happen? Because very frequently patients who have aortic valve replacement had a bicuspid valve in the first place as a cause for replacement. And remember, bicuspid valves are associated with a disease of the aorta which predisposes to aneurysm formation. So you have to follow up patients who have prosthetic valves also with respect to the aorta. And you also have to be very liberal with the indication to operation of the ascending aorta in patients who have bicuspid valves. But not only the ascending aorta is a target for transthoracic echocardiography. Remember, we can also see the descending portion of the aorta here. And this is a patient who had an aneurysm and also a stent placed within the aneurysm. But around the stent we have thrombosis. This is nicely visible with the help of transthoracic echocardiography. We can even see the flow right here within the aorta, and we can also see that the aneurysm protrudes towards the left atrium, causing some form of narrowing and maybe even obstruction of the left atrium. And if we place the transducer on the abdomen and look at the abdominal aorta, we can sometimes even see aneurysms there. Here is such an example, a very large aneurysm with a thrombus and a central lumen.
Now this concludes the case examples on dilatation and aneurysm. Next on our agenda are dissections.
How good is transthoracic echocardiography to detect dissection? Well, the sensitivity lies somewhere in the range between 77 and 80%, and the specificity between 93 and 96%. But remember, always confirm your findings with other imaging modalities, especially because you also want to know how the dissection extends and what the other portions of the aorta look like. Here on the right you see a beautiful example of a very large intima flap which ranges right from the area of the coronary arteries towards the ascending aorta. From this image it's very difficult to say where the false and the true lumen is. There you would need color Doppler to confirm. But why is it sometimes good to perform other imaging modalities? Well, remember the chapter on artifacts? Well, we can have an artifact which looks very similar to a dissection. Here is such an example. This in reality was not an intima flap, but only a reverberation from the anterior wall of the ascending aorta. Another example, this time a short axis view, where you can see the intima flap here. And also, if we point the transducer in the same patient downwards and look at the descending aorta with the help of a subcostal view, we can also see that there's a dissection here. So we can assume that the dissection extends all the way down to the descending aorta. Therefore, it must be a type 1 or A dissection. If you study patients with dissection or aneurysm, don't forget to also look at the aortic valve and to the presence of aortic regurgitation. There can be a number of reasons why patients have aortic regurgitation. Either because the aortic root is dilated, then you usually have a central jet, or because the patients have bicuspid valves. Remember, bicuspid valves and aortic valve disease are very closely linked. Or it could also be that there is an intima flap which protrudes right into the aortic valve and thereby causes aortic regurgitation. Here's an example of a patient who has a dilated aortic root and aortic regurgitation. Note that the jet is central and that the morphology of the aortic valve is rather normal. So always look at the centricity of the jet and also at the morphology of the aortic valve. Sometimes, even with TTE, it is possible to see a thrombosed false lumen. Here is a 3-chamber view where we can see the intima flap and the false lumen, which shows a thrombus. The same is visible also in a short axis view, an atypical short axis view, right here. This is a thrombus and this is the intima flap. To get a better appreciation for dissection, it's necessary to perform a TEE study. Here's such an example. A short axis view of the descending aorta, where we can see that the intima and maybe even portions of the media have peeled off from the aorta. Here's a long axis view where you can see 2 extry or entry sites actually, with flow into and out of the false into the true lumen. Here we see in a more cranial orientation of the ascending aorta that there is sludge, slow flow. So we can assume that this is a thrombus in formation. And if we go even further cranially, we see that we already have a clear-cut thrombus with only partially perfused false lumen. The intima flap can have various thickness. It can be very thin and very mobile, as you see in this example of the ascending aorta. This here already is a portion of the aortic valve. But transesophageal echocardiography also offers us to look at aortic syndromes. Here's a very large plaque which is ulcerated, where we also have intramural hematoma. This certainly needs some form of treatment. Another example, this time a long axis view, where we have a very large plaque which partially obstructs the lumen of the aorta and which looks very suspicious. We do not know if this is really an aortic syndrome or just a large plaque. To further confirm or to make the diagnosis, it's necessary to use other imaging modalities, such as CT, for example. And a final example, a case where we have a very large structure here, circumferent in the region of the descending aorta, where it's very difficult to say if it is an intraluminal thrombus, a partially thrombosed false lumen, or just a very large atherosclerotic plaque.
In conclusion, a few final suggestions. Use the suprasternal approach more frequently. Learn how to image the aortic arch. Only then will you be able to detect pathologies if they're there. Also, use color Doppler and pulsed wave Doppler, especially in the setting of aortic dissection. This helps you detect exactly the direction of flow and to evaluate which is the false and which is the true lumen. If you have patients who have a dilated aorta, always look for a reason. And if the patients do not need to be operated, at least follow them closely, with echo or with other imaging modalities.